All right, I think we'll go ahead and get started and people can continue to join. Hello, we're kicking off the fall semester for a lot of people, so thank you for joining us. Today we have Dr. Bratberg joining us. So we're so excited. I'm going to start with just a few admin announcements. Just regarding the CE credit, there is free CE today. So I will be putting all of the codes and stuff in the chat towards the end of the seminar, as well as I've already put my email in the chat. So if you guys have any questions or having trouble logging on, feel free just to shoot me an email and I'd be happy to assist with that. And so I'm going to welcome Dr. Salgado, our director here at CPPI, and she's going to formally announce our speaker today. Thank you so much.
Excellent. So thank you so much, everybody, for being here today. We have with us Dr. Jeff Bratberg. He studies the essential and emerging roles of community pharmacists and how they play a role regarding opioid overdose, harm and reduction, and opioid use disorder treatment. He is a clinical professor of pharmacy practice and clinical research at University of Rhode Island. He advocates for pharmacists' expanded roles in medication access, public health promotion, and policy change. He also serves as associate editor of JAFA and is on the board of directors of the Association for Multidisciplinary Education and Research in Substance Use and Addiction. He also co-produces and co-hosts a weekly public health pharmacy podcast called The Regimen with his University of Rhode Island pharmacy students. So we're very excited to have you here. Thank you so much. And I'll turn it over to you, Dr. Bratberg.
All right. Thank you very much. Glad to see everybody here. Welcome to fall. I hope it's feeling fall-like in Virginia. It's let's keep those hurricanes away, right, everybody? So one thing that I really like to do is to engage folks. I've given lots of these talks virtually. So please jump in the chat if you have questions. If you have a question that you don't want others to know that you're asking, feel free to private chat me. I won't call you out. We're talking about a public health emergency, and so we'll get started here. Hopefully we'll have lots of time for questions at the end, but happy to answer any questions that come up as I present. So I understand that that you will have all this credit information in the chat as well. So we have those things. Here's we used to call it a new building. It is 11 years old now. But this is where we are, view from our medicinal garden. Of course, we here in Rhode Island do respect the folks who had the land before us, so you can take your time to read our land acknowledgement. And so the first thing, too often lectures start and people just talk. That's kind of boring. So why don't we see if you're awake and not multitasking, because that's a myth. And someone tell me what they define marginalized as. So that's in the title here, care model for marginalized people. Somebody jump in, give me a definition for marginalized.
And for those in the classroom, there's mics, so feel free to use that and hop on it.
Okay, we got underrepresented populations. Okay. I'll include that. Let's hear a couple more. Anyone missed by care? Okay. Adult specific population, adult sickle cell. Okay, good.
Historically disenfranchised groups of population.
Historically disenfranchised. Good, exactly. Groups treated as separate or othered. Oh, this is great. Let's keep going here. Oh, people are even participating. It's great. We love the comments there. Maybe I'll add another challenge, or we'll try to get one more. Perhaps all of those groups politically disadvantaged. Oh boy, yep, there's that. One of the things I think we talk about in this subject, we talk about buprenorphine, and again, I'm assuming everybody knows what buprenorphine is. I probably shouldn't make that assumption since our education is not that great for buprenorphine in pharmacy yet. Hopefully with some of the things that we've done this becomes a more important and essential topic to talk about in the context of treating marginalized people. And of course, marginalized people are those with opioid use disorder. So one of the things that we'll talk about with when we get into the sort of the CPA or collaborative practice agreements is talking about healthcare delivery that impact pharmacy practice. That's distinctly there. The trends in practice as they relate to interprofessional collaboration. These are the standard learning objectives here, practice innovation. So we'll talk about our CPA here, and then role delineation, what they actually did. So I'll go through some of the steps in our training that were there for our pharmacists here in Rhode Island and beyond. So I'm going to just read these questions just to sort of get you thinking about things, and then we'll go over them at the end, and everyone will get all the answers right. So great class when everyone gets everything right. So which of the following has been documented as a barrier to accessing buprenorphine? I'll ask a separate question. Why do we have barriers to accessing medicine at all? There you go. There's the whole theme of the CPPI. So we have manufacturer drug shortages, a patient's skin color, removal of the Data 2000 waiver, or COVID-19 telehealth, temporary telehealth expansion. We'll talk about the elements of the Rhode Island CPA. So what was it that permitted pharmacist initiation of buprenorphine in the community pharmacy? Was it DEA state registration? Was it provider status permitting payment for services? Was it our patient-initiated saliva toxicology testing, or DEA audio-only controlled substance initial prescribing? So we talked about care retention in our CPA, and it was higher than what are the other following initiation. And I will exchange initiation and induction, again, assuming when we talk about buprenorphine, it's described as induction, stabilization, and maintenance. We prefer the term initiation, as with other medications, to normalize this extraordinarily life-saving drug. So when we look at other practice settings, this is the biggest challenge here, I think. Outpatient provider office, 30-day retention rates, emergency department referrals, and inpatient addiction service referral, or all the above, compared to what we achieved in community pharmacies. And then which of the following wasn't a task, going to that interprofessional care, delegated by physicians in our CPA to pharmacists at visits for, again, initiation, stabilization, and maintenance? Perform a clinical opiate withdrawal scale, review the prescription drug monitoring program, or PDMP, perform an oral toxicology, or sign the prescription for buprenorphine. So we published an article in January this year in the New England Journal of Medicine, and got lots of press because we have great press departments at both URI, Brown University, Lifespan Hospitals, and Brandeis University, where the team originated or are headquartered. But I think what I like to start with is whenever there's what some have called a groundbreaking intervention, it's to find out how did the media cover it, right? You know, what kind of interviews. So from February, State Line, which is now its own entity outside of the Pew Research Group. So one of our pharmacists who, of course, went to URI, got the best education in the Northeast. So he said, my experience with patients show me that many people seeking treatment face homelessness, stigma, judgment, and economic barriers. And that is the focus of all of pharmacy, shouldn't it be? Or all of medicine, is we need to close these widening gaps, both, again, economic and behavioral. So coming into a pharmacy and being greeted by a pharmacist who wants to sit down with you and talk about being healthy was appreciated. I think that's appreciated across all disease states. Terranova said he and the pharmacist found the program rewarding. The improvement we saw in our interactions with patients to feel their gratefulness that they weren't used to, think about that, was extremely rewarding. I'd be more than willing to jump in if we were to ramp up the program and participate and continue what we started. So then we looked at our colleagues in medicine, one of the signatories of our CPA. What we have in this epidemic is a workforce issue. It's not in my slides, but it's important to know when we talk about the needs of the healthcare needs of those who have OUD and want treatment, we literally don't have enough providers. I think that's different now that the waiver has gone away, but we need more providers. And so as Dr. Rich said, we don't have enough bodies prescribing buprenorphine. Physicians had 20 years to do it. And current evidence here in August 2023 is that people with the DEA are not jumping on to prescribe buprenorphine, so we need other avenues. Pharmacists are the most highly trained and underappreciated health professionals. We all know that. They're in the trenches. they see what's going on, and they're up for the task. So let's take a step back and go to drug use. So again, a lot of what we talk about is probably, again, a whole entire class that I actually teach here at URI on opioid use disorder talks about the motivations to use drugs, how drugs fit into society. We all use psychoactive substances. We just, depending on our life situation, economic situation, what drug it is, what state we're in, what country we're in, we're treated differently. So even when we look at sort of substance use, thinking of things that are illegal, there are those who don't use, that's fine. We use drugs for benefit. Pharmacists are medication experts. That's where we're headquartered. You can use legal or illegal substances non-problematically. Lots of people do. Then we get to problematic use, where there's perhaps a medical intervention for a biopsychosocial disease. Notice it's different from problematic use to potentially harmful use. Can't just assume that the problematic use is harmful in short or long term, and then goes to substance use disorder. But remember, 90% of people who use drugs don't actually meet the criteria for an SUD, right? So lots of people are using drugs. They may be using drugs that are stigmatized. They may be people themselves that are marginalized. It's important to think of this continuum, and those who are using without regard to consequence, which is really substance use disorder and essentially harmful. And there's a cascade of care. Those of you who study HIV, Dr. Williams and colleagues have really published well on the cascade of care, but paralleled to what we see in HIV, where we have those who are at risk or diagnosed with SUD. Current population estimates, some of the work has been done with my colleagues in Massachusetts, between 5 and 8% of the population at risk or diagnosed with. Did they receive an intervention? Did treatment get initiated? Did they retain in treatment? And then are they in recovery, which is, again, a broad recovery month is actually September. International Overdose Awareness Day is this Thursday, August 31st. So there should be things going on to respect those who have died, or those who know people who've died, which is probably almost all of us at this point. So in this cascade of care, think about pharmacists' roles here. We have a role in screening. We have a role in linking people to care. We have that role in treatment initiation. Again, for those who are willing, forced treatment does not work. It's a failure. It's policy failure. And then once they're initiated, why do they keep coming back? So some of those quotes should bring to mind of what we experience. Why do we go back to a restaurant or a store where we receive service, or a physician or a pharmacist? Why do we go back to that care? And then if you have it initiated, you've wanted it, you're initiated it, accessible when you want it, you get retained in treatment, understanding the life situation that we all have. And then we've got recovery, which is defined differently, which may include drug use. It may include no drug use. You have to really, really think about how we define people in recovery. But we have limitations, which we reviewed. So again, few people receive meds for opioid use disorder. The most life-saving drug on the planet is buprenorphine, reducing death between 50 and 79% of the time in the data. Pharmacists can't give methadone for OUD, but if you travel not very far to Canada or to most of Europe, or Australia, you're going to have pharmacists dispensing methadone. We don't do that. There's a trial that's kicking off, talking about methadone next month in Connecticut. So we can't do that. And then at the time of the study that we did, pharmacists were not permitted to prescribe buprenorphine with a waiver. They weren't added to this waiver without state DE authority outside of a CPA. And I'll talk about how we figured out a way to do that. There's geographic barriers. I know you face that in Virginia. Rural folks have higher rates of poverty, of disparities in care, access to care, and really where community pharmacy needs to step up and do that, fighting even more economic wins as pharmacies start to close in those areas where they can provide the most care. Medicaid insurance and barriers to prior authorizations, those are huge limitations to especially certain forms of buprenorphine. Underlying all of social determinants of care, structural and systemic racism, which is distinctly and overwhelmingly has a negative influence on how we treat people who use drugs, how we get them access to care, how they want to have care. Are they offering care in the carceral system? It's not a justice system, which again, adds more stigma when we call people criminals who disproportionately are Black and brown folks. So systemic racism and substance use disorder or use of substances or possession of substances are inextricably linked. And to solve healthcare, we can use OUD in our solutions as a solution for other disparities of care in other places. During COVID-19 is where we saw this go. We saw more overdoses, significant double-digit increases in overdoses, because we thought that we could control the supply, which we can't. You can't shut the border down to get fentanyl in this country. That is a major bipartisan policy flaw that we should all fight as well. And so really it's the supply that is unsafe, which is why there's fentanyl in everything. If you know a stimulant user, there's probably fentanyl in their stimulants. So this is an all drug approach. Most counterfeit, I should say, maybe 20 to 50% of counterfeit benzodiazepines have fentanyl in them. And so we need to think of harm reduction or risk reduction for all those folks. Again, a lot of folks are using multiple substances. Polydrug use is a significant issue. And then if people don't have access to their medication because they can't travel, they have all these things, they've lost their job, all of those societal and structural determinants of health, they have less tolerance. And so as the supply becomes diminished, the iron rule of prohibition is that it becomes more potent and more dangerous. And even the things that have occurred, such as non-prescribed buprenorphine access, which is overwhelmingly used to treat withdrawal, or it's the most effective withdrawal treatment, or to treat disease because of lack of access to healthcare, or more likely because healthcare failed people. We have to take possession of the failure of treating folks when we look at 110,000 people dead every year, every single year. So we have a lot. Again, just when we think about where stigma is, it's everywhere. It's societal stigma. We don't accept criminals, and we criminalize drug use. We don't accept people who look different than us, or who act different, who act without consequence. People who 50% of the time have undertreated, untreated mental health disorders, which themselves are also stigmatized. We have a long ways to go. I don't expect in 30 minutes we're going to change minds here, but it's really, really to think about the role of privilege, the role of skin color, the role of our laws and policies that influence these things, and why it's so essential right now for pharmacists to take on the task of treating OUD. Again, so I talked about, we need to train people, we need to reimburse people, we need to get rid of abstinence-only policies, we need to change state policy access, state policies that further limit buprenorphine access as federal policies get better, and we need to do research, which is what we ended up doing. So one thing I think to think about, I don't know how many folks in the room are pharmacists or who are listening are pharmacists, but I think I really, really like how only a couple of years ago, the oath of the pharmacist, which we all say sort of at various points in our career, I'll apply my knowledge and experience to advance health equity, to ensure optimal outcomes for all patients. We have to really, really embrace that, really teach it, really live it, really reflect on it, and reflect on it by accepting the responsibility to improve your self-awareness. Thank you so much for being here. And then champion diversity and inclusion. I'm not an expert to dissect that. It should be respect the perspectives of others and mitigate my personal biases. And so, yeah, I've taken the Harvard implicit bias test, and I don't do well for lots of groups. I'm actively working on it. I work in this field. When you see some of the data, and so I can talk about where I presented some of these results, really, really important to think about these things and bring it up. You can't just have a diversity, inclusion, justice, equity class. It needs to be in everything we do. And this is why when I say if we can initiate and retain people on treating, we're using a stigmatized drug that society doesn't agree, for people who have been shunned and marginalized because of their drug use, who are using drugs because they've been shunned by the systems. This is where we can have a role, and there's significant state and federal interest and billions and millions of dollars over the next decade to really reduce, to meet Healthy People 2030 goals, which is reducing overdose death rates from 2020 by 2030 to 2018 levels, which are still unacceptably high, but it's a good goal. So I gave a presentation on pharmacist role in substance use disorder in North Carolina. See Dr. Hughes here. Thanks for joining. And one of the things I really liked was what's called the Quintuple Aim, which again highlights and added that fifth segment here. You probably heard of the triple or quadruple aim, which are the first three there, but advancing social health equity, for whom is quality improving. But we also have to think about burnout. We also have to think about costs. And then I mentioned some of the things, is like which populations, where are we preventing disease, are we identifying diseases, and then how do the patients like that experience? And so there's a lot of Venn diagrams here. But really the biggest thing I want to impact is that Black people face extraordinarily remarkable and just immorally, unethically limits to access. And so many studies have been done in terms of access to medications, again, that reduce death by half if you have access to it. But looking at equal groups, if we compare Black people or even BIPOC people, but I want to focus on Black folks, is that if they go to a clinician, they're less likely to get a prescription. Just not going to do it for initiation. If they go to the emergency department, they'll be offered buprenorphine less often. If we look at people who are Medicare eligible due to disability, so under 65, and we look at the number of provider visits, so it's not that they're accessing providers differently. This is this recent study by Barnett and the New England Journal. 50% fewer buprenorphine starts for the ultimately highest risk folks, opioid overdose, again, equal groups, in the contemporary time of fentanyl in most of the country, 2016 to 2019. It's unacceptable. Like that's not even, it's just despair. It's amazing. We look at Black pregnant folks, buprenorphine, more effective, most effective medication, which many states actually don't allow people to be on opioids if you're pregnant. It's a whole other thing, but we compare, this is done in Boston, we compare Black folks to white folks. They're 37% less likely to receive MOUD. There is no difference in the efficacy of buprenorphine on the color of your skin, right? Just have to say that. We look at maintenance, we look at database studies. If you're covered by Medicaid, 42% less people were prescribed if you were Black than white. And then COVID-19 did decrease access. We saw all those figures there, but did not decrease access for white people. There's system problems, and we're not going to fix it here, but it's important to think about who are we providing access to. So the group I'm part of, AMERSA, one of the statements I think is worth reading here, again, an interprofessional group of folks here. All people who use drugs should be treated with compassion and life-saving services. And why don't we just look at that? All people, all persons who use drugs, not even illicit drugs. I know that's where your brain went. It's all people who use drugs. And driven by anti-racist, anti-oppressive principles, anti-colonialist principles, whether they seek effective drug treatment, again, all drugs, or to reduce the harms of ongoing drug use. We don't kick people out of care if they use drugs. We don't kick people out of care if they don't use drugs. We can't afford to continue to ignore the structural racism that underlies substance use treatment and harm reduction for people who use drugs. It's a continuum of care. Wasn't on that cascade. So let's say you've overcome all those barriers and you go to your pharmacy, 20% of the time, they won't even stock it. They won't even stock it for initiation or maintenance. Naloxone won't be there either. Looked at my colleagues in Oregon, looked at, again, we look at the South versus other regions, independents versus chains. If it was available, there actually were different formulations available, so that's great. The DEA has said that they don't have caps. The wholesalers do as part of opioid abatement acts. There's customer demand, right? Why stock a drug that you don't, from a pharmacist perspective, or especially independent pharmacist perspective, why stock something that nobody's selling? And then, of course, buprenorphine, I can't ever say that it's not an opioid. It's the safest opioid. It's the most effective. It's the most life-saving opioid. But many parts of the country, pharmacists have stigma about prescribing opioids or access to opioids and things like that. So I work with APHA. I've been a delegate for a while here. So again, it's important that we think about the evidence. That's why your group is studying first-line treatment. It is in every guideline. And so APHA affirmed that. I helped write this statement too. If we have to have inventory, so we need to do that. It's medications to treat OUD. And then, of course, we need equitable access. There's that health equity, coverage, equitable access, not just pharmacists, but payers. Everyone has a role here. And then, interestingly, in 2022, before the waiver went away in December 2022, independent prescriptive authority, or I'll support collaborative practice authority to expand patient access to treatment or to meet patient demand. This isn't just trying to recruit people. There's folks who want treatment that are not getting it. So we had a study. I think the important thing to think about that I can answer questions later is that we had withdrawal versus we offer treatment for withdrawal. We offer treatment for induction. We randomized people to usual care versus pharmacy care. COVID happened in the middle of that, and we figured out a way to do induction or initiation. So I'll go to that. So here's too many words on this slide, but this is in our supplement of our NEJM article. So we recruited patients in a lot of ways. We went to emergency departments, outreach teams. People had to have a self-report of opioid use disorder and be interested in starting treatment. Rarely did they actually walk into the pharmacy. These were Genoa pharmacies, which are not typical community retail pharmacies. They're embedded in mental health facilities, but we didn't really enroll anybody who were going to the mental health treatment facilities. We got them from outreach and then word of mouth, because when you hear you can get the thing that's going to make you feel better, you tell your friends about it, and we saw that in our study. Pharmacists would screen folks when they walked in. These were not appointment-based. This was the lowest barrier access to buprenorphine, I think, in the world, essentially. So we went through, if they had no withdrawal, they could have facilitated home induction. Importantly, almost half of our population had unstable housing, and so we don't call it home induction, we call it unobserved induction or initiation. If they are in mild to moderate withdrawal, we could have a bridge regimen, and Rhode Island has lots and lots of bridges. We're the ocean state, so there's sort of a lot of themes around bridges you'll see. So they could get withdrawal treatment, but we let the patient decide, right? When a patient has been refused treatment, a majority of people actually had been on treatment, we got kicked out for any kind of number of reasons, none of which are life-saving or threatening things. It's most life-threatening when you don't give people access to buprenorphine, which may be a really big change in your head, right? I know there's probably folks thinking like, who is this guy? But I'm happy to answer your questions. So then referral for unobserved induction there. And then if they're in severe withdrawal based on clinical guidance, that we would just bridge them a regimen. We actually still have a 24-hour hotline where anyone can call and get diagnosed on the phone, get connected to care, go to a pharmacy and get the meds. We really just kind of flipped the script that instead of calling the number and getting a prescription, you went to the pharmacy, got evaluated, and physician would delegate the authority to initiate buprenorphine. So again, here are the steps just to show what happened. Patient shows up. Anyone being offered induction or initiation was offered money for the trial. If they agreed, called the research staff, again, performed a COWS screening test, would get them enrolled in the system, check their PDMP. Again, lots and lots of folks had buprenorphine in our PDMP before. Patient would complete all these forms, which are a lot of which were just to become a patient of the pharmacy. They could share their research so that they could get connected to services to help all their social determinants of health. In the interview, standard kind of intake interview here, pregnancy status, allergies, what's their insurance, are they employed, what drugs have they used, if they had overdose history of seizure, which is a minor point for buprenorphine, what was their past treatment, and then permission to contact their PCP if they had one. And then specifically, the pharmacist would enter the information. They would consult with either the hotline, Dr. Seth Clark or Dr. Jody Rich, issue a CPA prescription. And we sort of modified this. Lots of folks, it's known now, probably require more like 24 milligrams a day, especially in fentanyl times. Patients were offered the chance to talk to the doctor, but they never really did. So really almost entirely pharmacist guided. So I would call Dr. Delgado and say, hi, I have this patient here. I checked PDMP. They seem fine. Their COWS scale is 3. I want to start this. The physician will be sure. Patient want to talk to me? No, I'll see them in a few days. That's how that worked. So very, very low barrier care. They would make an appointment for their surveys that would go into our baseline data to be recorded later. They'd fill it in the name of the CPA provider. So pharmacists don't have DEA licenses in Rhode Island. We do not sign prescriptions at all in CPAs. It's always the provider's name that occurs on the prescription, which, since they're data waivered, We kept track of how many patients. They never went above their patient limit, and they always, and it was okay for the DEA in terms of doing that. The pharmacists would counsel them on home induction steps. We had some nice forms from the California Bridge program in San Francisco, well, all over the country now, and Yale, New Haven had their addiction ED program, has lots of great forms, pictograms, low health literacy kinds of things. Nothing that was really translated. That's the question that's come up. So when we look at, so what, man, that's a lot. I've been talking forever. Any questions? We'll take a little pause here so you can type it in the chat or ask in the room.
I've been meaning to ask this question, but
Yeah.
I was waiting till the end. But now that you're
Go for it.
describing the protocol, I'll just ask it now. Is this intervention being funded by some of the opioid abatement funds that were distributed to the Rhode Island and the New England area, or not? And if not, is there appetite for essentially tapping into those funds?
We have presented to our very transparent and probably award-winning opioid abatement committee. We presented these data in May. We only started enrolling patients in the induction program. The 100 patients started with a couple in January 2021, and then we stopped enrolling about a year later, year and a few months later. So this was funded by the NIH. We had a pilot program to see if it would work in November 2018, and then we started enrolling in the randomized control trial, and then the induction form came as a modification when our CPA for induction was approved in July 2020. So right now it's not happening. This is not happening at all. I have a foundation grant to examine across the country what each state needs to do this. I have testified for a law to do this in Massachusetts, to change their existing law. I know Nevada has passed a law, Colorado has passed a law, and so there's lots and lots of interest in states because that's who authorizes pharmacy and medical permission for these things, to figure out how do we do this, what are the ingredients to do this, how do we get paid in this. So we helped pass a bunch of scope of practice expansion laws in Rhode Island just this last session. And our goal this year is to get provider status so that these kinds of things would happen, what Virginia successfully did in their CPAs. So in Virginia, if you don't have to sign the prescription, you can do this right now and bill Medicaid and all those other things, with a lot of steps in between, I'm sure. Did that answer your question? So are we seeking funding from the abatement committees? Yeah, I think that's a great way to do this. But ultimately, we need to be providers and have this be standard of care. Other questions?
I just have my thumbs up saying yes, but
Oh.
I was told that you can't see me. So, but yes.
No, I just see a yellow square. That's fine. Okay, great. So let's talk about how we enrolled folks. So here's our standard consult. Again, this is all in the supplement, the part that no student downloads unless you tell them that they have to, but there's a 48-page supplement and a 800-word letter to the New England Journal where this comes from. So we assessed for eligibility 171. We excluded folks who didn't want to participate. One person completed the study, didn't have OUD. Some folks were on methadone. 100 consented. 39 didn't show up, which is actually a pretty good number. Usually we see about half of people don't show up for their second visit in lots and lots of settings for initiation. One person didn't stabilize, one became a methadone patient, and then we randomized 58 folks. So in that randomization, again, we allocated to standard of care. So again, they all presented to the pharmacy, but for all kinds of legal reasons and study reasons, they all became part of the study and then sort of entered the randomized control trial where they'd go to standard treatment or pharmacy. So it wasn't just enrolling people at the pharmacy to be in the pharmacy, it was enrolling at the pharmacy, initiating treatment, and then they divided up as you see here. So when we look at 30-day retention, in the standard of care, only 5 were retained versus 25 folks. So they 19 people, amazingly, were retained in pharmacy care. They did not want to go and counter the healthcare system outside of this new system of care that we made. One was administratively delayed. Again, 3 were on methadone maintenance, 2 dropped out. So pretty good numbers there. We look at the retained. Again, we had folks drop out, 3 discontinued. So when we look at the analysis, it was 30 versus 20. So this is a small study, right? This is small, but essentially unethical to do again. So don't do this study, just do this work, I think is what we say. So our induction success rate, 58% were stabilized. They had 2 or more visits is how we define that. Again, in the primary outcomes, this is the highest percentage. I'm giving away the answers here. It's the highest percentage of initial engagement in any study. So even comparing a 2010 study that compared unobserved induction, or what's called home induction, versus observed induction, those retention at 30 days were 78%. We had 89%. Again, half or more reduction in people who dropped out of care. And again, 7 people randomized to usual care refused to leave pharmacy care, and we didn't refuse to give them medications because medication is life-saving. So I want you to think about, maybe pause here a little bit and think about, what if I replace the word buprenorphine with insulin? And 20% of pharmacies didn't carry insulin. And insulin, people didn't have access to because of the color of their skin. People didn't get started on insulin despite going to the same number of providers who could prescribe it. There are disparities in access to care and intensity of care and on that diabetes care cascade in terms of screening, but that's unacceptable. But yet this is still acceptable. These are facts that remain today. The Barnett study just came out from data from 2016 to 2019. We look at safety. Again, buprenorphine is the safest opioid. No one died, no unanticipated severe events. We still we gave out non-sterile syringes, non-prescription sterile syringes, and about a third of folks got naloxone. Again, remembering that all people who take buprenorphine, this is an HHS recommendation among others, should all get naloxone because they're likely in a situation where they can be first responders. We should all have naloxone. We should all carry naloxone. Hopefully you all have it. And by October 1, it'll be in your pharmacies as an over-the-counter product. The first over-the-counter product. So here's where we really look at sort of what I always talk about is like, we receive the most marginalized population, right? A third of them were unemployed. A fifth were disabled. Half of them had 1 or more lifetime overdose histories. Look at that recruitment, 35% word of mouth, 39% outreach. You can't just open up this service and think that people will come. You have to link to places where trying to get folks into care. 70%, again, we look at we really hate calling it polysubstance use, multiple substances use. A third cocaine or crack. 44% were using prescriptions. They're going into pharmacies and getting their prescriptions filled, not being offered naloxone, not being screened, not being initiated into care. 91% used Bupe before, 71% used prescription. So we saw them in the PDMP. 69% admitted to non-prescription use, almost half admitted to both, because they still have this relapsing, remitting biopsychosocial disease that exists until we can address housing as a human right, employment as a human right, and work every single day to mitigate the effects of systemic and structural racism. 80% of people were in mild withdrawal. So if you think about standard of care for buprenorphine, you have to wait till you're in withdrawal and then you start treatment. That's, I don't know, doesn't seem like we do that with other things. And again, dose is important. Over 16, 92% was equal to or greater than 16. At the end of the study, we had lots and lots of visits. Of our pharmacies, 6 pharmacies that we used, half of them were used. Most of them went to 1 pharmacy in Providence, Rhode Island. 43% we had study transportation. Can't go to your appointment if you don't have transportation. 31% we gave them phones. 46% had payment assistance for the first month of 3 months of therapy. I'm running out of time here, so I just want to emphasize this. So we look at the Rhode Island population, about 20% of folks identify as BIPOC in the 2020 census. In our study, we had nearly double the amount of Black or African American identifying folks. That's why my focus is on that group. Same number of Hispanic folks, despite our 2022 data that I believe is public now, where we saw a 50% increase in Hispanic deaths, something that as a state committee we're trying to figure out. 76% no reliable access to a vehicle. Remember I said we offered vehicle access to a lot of folks, and 44% were unhoused. So in our pilot, we actually collected, in 2018, we collected some of these quotes from people, what they felt like pharmacy access to buprenorphine was. I feel comfortable bringing my babies to my pharmacy. The hours were perfect. I wasn't embarrassed. It's convenient. They want me to be here. No surprises. I was excited to go to the pharmacy. I met with them, got to talk down. I can't do that at the OTP or opioid treatment program. They're courteous, friendly, more personable. And this person's quote, than a large retail chain pharmacy. I didn't have to stand in line and have people in my personal space. There's a lot to unpack here, but I think this is what's important is we have to ask the people with lived or living experience, what do you want out of this? So what affects implementation? So I talked about referral, which is highlighted there, talked about payment for services. We said in our article, the reason this doesn't happen, we're not getting paid to do this work, that 45-minute initial visit, the interpretation of lab tests, saliva-based lab tests, state rules. Certain states literally have the same rules and limits on who can get what products at what dose. They are difficult to change. Think about where healthcare workers are short, including pharmacists. Think about where there's addiction training programs, have them consult. Look at, again, I talked about research being done for methadone in pharmacies. We didn't have state DEA recognition. If we want that independent prescribing authority, you need a DEA. States need to allow that. DEA federally doesn't really care. We need to bill for those lab tests. We didn't do that. We paid, the study paid the pharmacy a set amount of money. You need your, to expand the clinicians who can participate in CPAs. We only allowed physicians according to our law. We should allow nurse practitioners and PAs. The CPAs in Rhode Island, which was passed in 2000, unlimited number of pharmacists. So we didn't have to have one-to-one CPAs. Who can sign the prescription? Again, that I don't know if that really matters. If I were to do the study, again, I'm not going to do a study again, but if I was to do this, I would make sure that we have peers, peer recovery specialists, social workers to help with social determinants of health. This person wants treatment. They likely have been in treatment. They likely been on the medicine. That's not the issue. It's everything in life that, for any chronic relapsing remitting disease, it keeps us from care. Your CPA needs to allow initiation of therapy. Some don't. They need to not ban controlled substances, which some do. And then what are the training education requirements, which should be equal to our interprofessional partners, which is really the 8-hour, what's called the MATE Act training that may actually allow for more buprenorphine. So patients inducted attain stabilization comparable or better than community-based usual care. Transitions imposed by study systems and stigma disrupt engagement and maintenance in care. Patients should maintain care in the pharmacy or be given the choice to do that. We can attempt to take steps towards more economic equity and medication treatment access, or I like to call it treatment. It's the most effective treatment. Some folks may ask about, did we offer counseling to do this? We did that through social workers at the study addition service at our major healthcare system Lifespan. But we don't need counseling to be on medication. You'll die waiting for counseling if you don't have meds. That's the fact. And so we need more research to identify what other supports are there. I talked about peers, social supports, material supports to optimize induction rates. My colleague and URI grad, Alyssa Peckham, formerly of Northeastern University in Boston, published this fantastic thing about opioid pharmacist roles. You can look at that. Some other colleagues, Stigma and Watanabe, and other folks talk about what we need to do to change things. And then we'll just get through these questions and answer some more questions from you. So which of the following document is the barrier to accessing buprenorphine in the US? Maybe you guys could all chat this. What answer you think? Or yell it out. What answer? Okay. Yes, it's B. All right. Key element of the practice that permitted pharmacist initiation of buprenorphine. Type in your letter. I didn't emphasize this too much. Probably know what it's not, though. maybe I'll go through this. So I said that Rhode Island doesn't allow us to get DEA licenses. We don't sign the prescriptions. We didn't have payment for services. It was all study funded. Saliva toxicology is allowed by our CPA. So it really was the DEA in March of 2020 when they allowed DEA and SAMHSA allowed initiation without patient examination, which is the Ryan-Haight Act of 2008, to allow controlled substance initial prescribing, which has been proposed to be severely limited and limit patient care and result in patient death, as we wrote through EMERSA. It's now extended to November as they go through 38,000 comments to their proposed regulations. So we'll see in November if there's a separate prescribing authority, something to stay tuned to that will affect the benefits of telehealth. Community pharmacy-based CPA initiated people in 30-day retention rates at 89%. What is that higher than? It's a little easier question, I'm guessing. D, that's right. So I did a deep dive of the literature, really couldn't find that 89% care. I mean, I was trained as an infectious disease specialist, and I always ask my students to say, what antibiotic works 100% of the time? And they don't. Most of those studies ended up being 89%. So I think we doing pretty good for when we use those things. And then which task did we not get delegated? Here's another easy one. I think it's sign the prescription. So they can review the PDMP, perform the test, perform the cows. All those are delegated, but the prescription was always filled out by the pharmacist from the physician name. So there's lots more here. There's a video we did which really talks about it. Again, I have a podcast called The Regimen. If anyone wants to be on our podcast and be interviewed by my students, we should do that. The episode's on YouTube, and you can follow us on our media empire at Pharm.D Pub Health. So that's where we're at there. I'm going to just close this out and take questions.
I have a question. Jeff, how many pharmacies did you say were involved in your study?
Yeah, 6. So in Genoa, it was all the Genoa pharmacies were 6. Important to know, Genoa is the 5th largest pharmacy chain in the country. So they're been a wonderful, wonderful partner. I'm sure a lot of us find it rare that you can partner with large chain pharmacies. One of which is headquartered in Rhode Island that I have worked with as well. So, oh, you're muted.
Well, this was so, yeah. I want to speak through the mic in the classroom before this whole thing. You can hear me okay, right?
Yeah.
Yeah. So I was wondering if you would have some tips or suggestions on how to coordinate, well, how to engage with the chain pharmacy, how to coordinate the work of the different sites, sort of a little bit more into the logistics and the behind the scenes that takes place so that we can, as practitioners and then as researchers as well, sort of understand what goes into it.
Engaging with large companies is always difficult. So we have to go sort of at the top 10,000 foot view. Particularly this issue, much as wholesalers have opaque and what I would think, and my colleagues agree, are patient harming policies, opaque policies on how much to order and what to do as part of the opioid abatement settlement. So, they're paying literally billions and billions of dollars each year. Doing research on this should be an easy case, or engaging to do service or talk to pharmacists should be good. But I think, I don't know what specific reason, but I can hypothesize that it's from an exposure standpoint to not engage at all in this particular kind of research. So I don't really have any ideas other than just engage them. Genoa is really engaging. I've worked with a West Coast supermarket chain as part of some of our other studies. It's very difficult to do. Again, I'm an editor of Jaffa. We see lots and lots of great articles from independent pharmacies, but it's rare to engage with a large retail chain. And I think it's more difficult, particularly this issue, but I think really anything. I even heard, I shouldn't hypothesize, but I've heard that pharmacists, but out of their own their own use maybe, or the company are told not to talk to researchers. So that's a really concerning thing, but it requires validity. And I wouldn't say don't engage people because you heard this from me. I would say, this is something we need to validate. And as a profession, we need to say this is, we have to do workforce analysis and qualitative studies and quantitative studies to know how to do it. We get asked, we got this as it's a public meeting, so we got asked this question about how do we engage large retail chains headquartered in Rhode Island, and we're open to them. They need to come to us. Public-private partnerships, I think, work well. Genoa was, there's a phrase in Rhode Island, and it's called "I know a guy," which is, I know a person, I should say, and we just sort of have a tight-knit group, and we know folks, and they came to the table. We were not expecting to have a partner, right? And so we picked them and worked out. So a lot of luck, like research is sometimes. So that's an unsatisfactory answer, I think, but